since you brought it up.
Okay, so it's basically, how
You can stand up and demonstrate if you want.
Okay, so it's basically, you're in space, okay?
Okay?
And your body has to know, like, where you are in your space, in your bubble. Like, where your arm is, like, even though, like, it's not gonna, like where it's at. So people that don't have good proprioception, they're gonna be very clumsy because their brain is sending a signal to where they are in their space.
Okay. So everybody stand up and pick one partner. You're right.
Just because I don't have good proprioception, I learned it yesterday.
Okay, so one person close their eyes. One person. So the other person do like raise their arm, hand, do something. No. On the person with their eyes closed. You guys close your eyes. Even that, Carly. Okay, so the person with your eyes closed, do you know where your arm is?
Yeah.
That is called proprioception. So with your eyes closed, someone is raising your thumb, raising your toe, raising your hair. You sense that and that, so you could say, yeah, she pulled on my hair on the left side or whatever. And you are realizing that. Okay, you guys get that?
Yeah.
Proprioception. All right. What's next? Occipital lobe. That's the easy one. Vision. That's just eyes. Vision, period. Cerebellum. Balance. Coordination.
What'd you say? She said vision. I didn't get to sign in.
Never mind, I'm sorry.
I didn't either. I have to sign in.
So, okay, so what's a cerebellum? Does everyone understand that? Judgment. I can walk, I'm not clumsy. Oh, sorry.
It's a
Wait, let me see that one for a second, Mara.
Huh?
Mara, let me see that one for a second.
Oh, sorry.
It's the answer key.
Oh, sorry. I mean, I want it too, but.
All right, so I can walk fine. I can, like, it's kind of like dopamine. You have smooth muscles, muscle movement, balance. You're not falling over, stuff like that. All right, how many layers of the blood vessels do we have in the brain?
Three. We didn't go through brainstem.
Oh, that's not your brainstem. Sorry, brainstem. And 3 is wrong.
Breathing, regulation.
What? Google is wrong. So what's the brainstem control?
Breathing, regulation.
Breathing, heart rate. They are our lively stuff. So any damage to that brainstem, it's not good. So the brainstem really needs to remain intact. They control our heart rate. They control our respiration rate. They control fever. So if you have damage to that brainstem, you might have a very low respiratory rate, you're severely bradycardia. You might have fever that's 106. I've seen it as high as 107 with brainstem injury.
Is that why the neurogenic shock we have the low?
So you're connecting the neurogenic shock with bradycardia and low respiratory rate. Everything's low with neurogenic shock, right? All the other shocks, those two are high, but with neurogenic shocks, they're low. All right, brain vessels. You already said there's 3 layers, but there's actually only 2 layers. So that's why it's so important that someone is not severely hypertensive, because if they're severely hypertensive, we're worried about a stroke. They can burst those vessels. So we got to make sure that we keep a regulated blood pressure. I was going to say something else with that. aneurysms, that's why they're so prone to rupture in the brain, is because there's only 2 layers of those, are blood vessels in the brain.
So what are the 2 layers called?
Pardon me?
What are the 2 layers called?
Are they called, can they be, are they called meninges?
Pardon me?
Are they meninges?
No, that's the layers of your, the covering, that's covering the brain and spinal cord. These are the actual blood vessels within your, like your circulatory system to your brain.
Do you want them now or after?
Okay? So what about, well, so what's a blood-brain barrier? So it's a network of cells and proteins, but what is it protecting? It filters to protect the brain from harm, any chemicals, any medications, any drugs. But there are some drugs that can get through that blood-brain barrier to damage the brain.
Like what? Like what? Can you repeat that?
Like what? Any drugs.
Are
Bad, not
you talking like medications or street drugs?
both.
So like with.
It's like street drugs can puncture or get through the blood-brain barrier. Trauma can damage that area and get through the blood-brain barrier, and that causes further damage to the brain.
So that's why with Parkinson's disease, given the carbidopa combinations, we can cross the blood.
We gotta check Google. Yeah, we don't wanna check Google with that. But that's okay. We'll come to that next week. Yes. Are you just waving?
Yeah, I'm waving at my friend.
All right. What does the cerebral fluid do?
Protection, support, nutrition.
Yeah, it's kind of like the blood, but it also controls buoyancy, so our brain is just kind of sitting, resting in there.
Regulation of intercranial
Jiggling
pressure.
around.
Where to find it?
Move your head.
Yeah.
That's why we have
Thank
to
you.
worry about kidney, like, this stuff.
Shaken baby syndrome, true. But if you fall, your brain is gonna hit that. And then the other side, I don't know, we do TBI today. That's okay. All right, so cranial nerve test. This should be a review. What's cranial nerve 1? No. How do we test that? Close your eyes. Close your eyes and smell. So you're giving me coffee, and I'm closing my eyes, and I'm saying, "Can you smell this?" And I'm saying yes. Is that correct? How I test it?
No.
What is it? Is it an orange? Is it coffee? Is it alcohol swab? Is it something that is easy recognizable? So yes, you are having them close their eyes, having them smell something. And in simulation today, we will be doing all this. What's cranial nerve 2? So how do we test that? There's a couple ways you can test it. Snellen chart. What if you're walking down the street, someone's like, "Ooh, I don't know what's going on." How are you gonna test their occipital lobe or their?
Fingers modeling out triple. How many fingers modeling?
How many fingers are you holding up? What if you're you're in the ED, you don't have a Snellen chart? What are you gonna do?
You can write some numbers down.
Write some numbers down.
Oh.
Read my name tag. What does my name say? What time is it? So pick out things that they can read, because they should be able to read. These are quick assessment things, to check their visual acuity.
That's it.
Yes. Got it? 3, 4, 6, those go together. Did we get John? Oh, we didn't get that far. So 3, 4, 6, those go together, right?
Yes.
3, 4, 6, your eyes do tricks. So we're looking up, down. Your eyes do tricks, they can move. So we're looking at the muscle movement in all of your eyes. 3, 4, 6, your eyes do tricks.
I like it.
I'll tell you, the first time I taught this, the students told me that. I go, I've never heard that before, so now it sticks. There was another thing that I was thinking of, but. All right, number 5.
Not in this.
Hmm?
Oh, sorry.
Trigeminal nerve. What are we testing?
The cottonwood. Facial sensation.
Facial sensation. So yes, cotton, can you feel this? motoric, whatever, what else? Because it's, 5 is both, sensory and motor, what else can you have them do?
Clenched jaw.
Clenched jaw, good, chewing, but the thing is, if you're clenching your jaw, you're looking at it, it's kinda hard to tell, and it's really hard for a patient to fake it. So I always feel that when they clench down, like if you clench down and feel your jaw, you can feel the muscles on both sides. So if someone's trying to fake it, or and people with strokes do try to fake that they're having deficits, you can feel one side or the other is weaker. All right, we did 6, what's 7? What? Facial. So facial nerve, what are we assessing? Smile, raise your eyebrow, so puff out your cheeks, muscle movement. This is one of them that we do, for a stroke. Do they have facial droopiness on one side? 8, we kind of talked about. Hearing, right? So we're listening, whisper test, we're telling them a secret, can they hear it? Can they hear a ticking watch or something like that? Just figure out. 9 and 10, I kind of do those together. Swallow, gag reflex, and you don't, your patient today will not come in tomorrow for simulation, does not have to do the gag. Just say, it is intact. We're not gonna be mean. So 9, 10 gag, what is the vagus nerve also? How do we know that they have a heart, or have a heart? It innervates the heart. So if they have a heartbeat, most likely it's working. Right? 10 vagus nerve, what about 11? Oh, 11, shrug your shoulders. Movement. Okay, and 12, stick out your tongue. Yep. Is your tongue going straight out? Is it deviating right or left? So you can see if there's any kind of muscle deficit. Most people will stick their tongue out right, but sometimes, so if I have a left deficit, right-sided stroke, left deficit, where's my tongue gonna go? It's gonna go to the left because my right side is strong, so when I stick out my tongue, it might go to the left. So, because the right side is overcompensating.
So does it go left or right?
Pardon me?
So it goes to the unaffected side?
It goes to the affected side. Because my right side is strong, so my right tongue will go, well, but it will go to the left side. It will be different than the trachea. Okay, but you will need to know the cranial nerves. Associate the cranial nerves with disease processes, like, and then some of them might be chronic for next week. But you will need to, what are we testing for the Glasgow Coma Scale?
How alert they are?
How alert they are, what's another word specifically? Level of consciousness, that are we, and what kind of number do we want? The higher or the lower?
The higher.
Higher, 15 is, the highest, so priority wise, we have a Glasgow Coma Scale in, 12 in one room and 15 in the other. Who are we gonna go see first? 12. Because they have a lower level of consciousness than the other room.
The lowest is 3.
Okay, and then we'll get, if this ever comes up, we'll go further into it. This is really driving me nuts. Because what is, I think I do know what this. So what are we testing with the Glasgow Coma Scale? What does that mean, eye-opening? Can they open your eyes?
And how are they, like, when are they opening their eyes?
What do you mean by when?
Like, is it spontaneous or when they're telling you?
What would be considered spontaneous? So when I walked in the room, all you guys looked at me and I said, good morning, everyone. So you guys all scored a 6 or a 5 on that. 4. But you guys were all aware that I came in the room. So then the next one is what? So aware. Let me go back to the eye opening. What if other ways is you don't realize or open your eyes until I say something or until I touch you, or you just don't realize at all. So those are the other components of eye opening. response.
They're oriented,
They know what they're saying, we can understand what they're saying. What if they have a stroke and they have a broca area issue? They're gonna be slurred or just saying 5 inappropriate words, right?
inappropriate or incomprehensible sound.
And what was that number? 2. So, sometimes when someone has this incomparable with the Glasgow Coma scale, and Justin, I might ask you about this because I'm sure you do this a lot, right? I tease it. But the Glasgow Coma scale, someone can pretty much be alert and oriented, but if they can't speak, do you lower the Glasgow Coma scale for a verbal response? Because some people say they don't, because they can write out their name, they can write out the date, they're still alert and oriented, but they can't speak, so that's why we gotta lower it. But if you say, where are you, and they're saying 5, but you give them a pen and paper, I'm at the hospital, they can write everything out, but they just can't speak. So don't always assume that someone is not, alert and oriented just because they can't speak. Find a way to communicate, because with neuro patients, that's gonna be your number 1 key, is figure out how to communicate with these people. Give them a pad of paper and pen and see if they can write everything out. All right, all right, the last one is what? Motor response. So motor response, do they move freely, is it spontaneous, or do they only move with pain? Can they only move, so that's what you're assessing. All right, Glasgow Coma scale, what are we assessing?
Level of consciousness.
Level of consciousness, okay. Proprioception, we already did that. What's stereogenesis? This has gotta be from A&P or first semester, 135.
It's been a minute.
Or not stereogenesis, stereogenesis. Do you remember where you would write, or you would put a key in someone's hands, the eyes closed, and they put a key, and I'd be like, yeah, that's definitely a key. Or you're putting a lanyard, well, that feels like a lanyard. I can identify it with my eyes closed. And then the last one is orientation. I don't think that's the right word. But the other one is I don't know, I can't think of what it's called. But that's where you write your eyes are closed and you write the number 5 in somebody's hand, and they can identify it. Eyes closed. My eyes are closed. Abby's gonna put a 0 in my palm, and I'm gonna say, yep, that's a 0 or a O, whatever it is.
You think
Okay.
what?
Which one was that?
Graphos. I know.
No, write down on the paper. Grapho something.
It will be in simulation this afternoon tomorrow. Hey, I'm just trying to get on this darn stupid. Yes.
Go up there, Abby.
All right, so I'm gonna call it. Did everyone sign this? That's here.
So what is that? Is that like an image?
This is it, yeah.
All right, so the next section, so those are normal responses. We went over some normal responses and abnormal. So now let's get in our groups again. And we're gonna do pages 1 and this one. Let's do just the next 2 pages. The front and back of the next page. What are you doing? Breaking it. Yeah.
What did you put for the acetylcholine? What did she say that one was?
Which one?
Acetylcholine.
I went to the bathroom.
Oh.
She went over that one, sorry.
Anything major?
No, so just whenever these.
And then we're just gonna go over, we're gonna do this and the back.
Next page.
Busy work.
Yeah.
Election.
I was worried about that whenever I saw our slides were only 10 pages. Or the outline.
Stalling because something's wrong with the. I don't think she can get the power plants. Might need to call IT.
Yeah.
It is.
Yeah, I had to write it in. But it's the same thing as up here. Frontal temple.
This is a bigger picture of it. Okay.
Are you supposed to write something in this part?
They'll do the front and back too, I guess.
I'm gonna skip it for a second and just go to the questions. I'm not sure what to put there.
Yeah.
See, this is why you need to apply the information. Everyone have a back page to your Okay, what's normal, what's significant, or what, so, why they're doing, so what's the significance of the blood, of the vital signs? Okay, blood pressure. Oh, you guys make it harder than it really is.
What's the normal A1C again?
6.9 or less.
Okay.
4 point.
Oh,
I know
never
no
remember.
more than 6.9.
Okay.
There's a vet. I know that much.
Okay.
I was like, I can't remember exactly what it is, but I know his is high. And then my other estimation.
So this week's notes start with this page. I've heard it next week's, and they are running together. Can I see
Yeah.
notes for this week?
The outline.
Yeah.
It's a cranial regulation.
And then the last page.
Is this
That
one.
one.
Yeah.
Okay. All right. Cool. Oh, it's thin. And next week's thin too.
Mm-hmm. Neuro too.
Yeah, it's kind of thin too.
Yeah.
That's a good thing.
Yeah.
just because he's diabetes, but like what Justin just said, low blood sugar mimics stroke symptoms, so that is one of the components that we do when someone we're ruling out a stroke.
Wait, blood pressure?
Blood sugar, sorry.
Especially if you have a history of
They do have a history of diabetes, but
Low blood sugar mimics stroke.
low blood sugar mimics stroke, so that's why we also check it. NAH stroke scale, do we know what that is? Look at anything. That's a 0, that is a stroke assessment. We'll be going through that in a little bit. You will not be responsible for knowing it on the test, but you will need to know it for simulation and all that. But in simulation, we'll have papers for you.
Well, that's the one with the lady, right? The lady in the video?
Oh, yeah. CT of the head is negative for acute hemorrhage or infarct. Do we want to know that?
Yes.
What kind of, when they did the CAT scan, is there any specific orders that went along with that CAT scan to test for stroke? What kind of CTs are, do we do it with contrast or not? None, why?
It's like an alternate,
What if you have a head bleed and now we put all that contrast dye in the blood system into the brain, now we're damaging all that system. So if we're questioning a stroke, the first CAT scan is non-contrast CT. Because if it's a head bleed, then we just say that their head full of contrast dye. So the first CT is non-contrast dye. Okay? Yes.
Oh, she said some have that, some don't. I don't know.
Correct. So if they're doing a second, like a lot of times, if someone comes in through the emergency room, they check and make sure there's no head bleed, and then they might go through and do another CT with contrast dye. They might be checking the head neck area to see what's going on, if there's limited blood flow to the brain. Because a stroke-like symptoms doesn't mean that there's a stroke in the brain. It could be low heart rate, it could be low blood pressure, it could be maybe their carotid arteries are a little full of plaque, so they might have lack of blood flow to the brain.
Must just be doing it.
Carotid ultrasound. So they're gonna be looking at the carotids, they're only 75 to 89 stenosis. EKG, why do we worry about an EKG? For dysrhythmia, AFib, because our AFib is a risk factor for a stroke, right? We want to make sure if they're in normal sinus rhythm, then most likely this, their heart rhythm is not the cause of it. Labs. Cholesterol, LDL. Yeah, more plaque. So what is specific about this guy's symptoms from, let me rack my brain and when I did this. So when did his symptoms start resolving? Within 15 minutes. So is this guy having a stroke? What is he having? A TIA. And that's how we define a TIA, is those symptoms resolve within minutes to 24 hours of their symptoms onset. So like this is probably pretty typical, where we'll get a call from a squad saying this person is having a stroke, but by the time the squad got to the ED, the guy's talking, the moving, or whoever, their symptoms have resolved, so we know it was a TIA. Now,
it's also a precursor to stroke.
which are precursors to the stroke, so how do we treat TIA? The symptom is already, the problem is already resolved itself, right? Education, cholesterol, blood pressure, take those medications, blood pressure within range, keep your cholesterol down, exercise, diet.
Well, you know he doesn't have a hemorrhage, did you put him on a blood thinner?
Yep, that's what I was gonna say, blood thinner, make sure that they're on anticoagulants. Because we don't, especially if they're in an abnormal heart rhythm, if they're in AFib, get them on it, Because if they're not having a stroke now, they can throw a clot later. So if they're in an abnormal rhythm like AFib, get them on an anticoagulant.
You said 15 minutes to 24 hours.
Minutes to 24 hours. 15 minutes was it?
For the TIA, it's 15 minutes to 24 hours. The symptoms
Just a few minutes to 24 hours, or 24 hours
at the most.
at the most.
They'll resolve within 24 hours.
The symptoms will resolve on its own. If it's a TIA. I think I can do this. But we'll finish. I'm sure I have more questions. Oh, this is just part of the more assessment piece that you have. Patient is anxious. Do we care about that? When they're anxious?
Yeah.
Oh, we're worried about the brain first. Anxious is kind of a side piece. Remember our test B question that just came out of the cardiac cath, or no, yeah? And they're anxious, worried about a blood clot. Well, we don't care about how anxious they are. We need to do our priority. We need to do our ABCs. And our brain is a higher priority than anxiousness.
Some of us have.
I know. We don't.
She doesn't care.
Is education a priority? No. So, okay. We talked about that. We talked about the timing, what actions does the nurse perform. I talked about that. It's education for TIA. Okay. So what can we do for TIA? Say maybe there's, they did the carotid ultrasound, so maybe now they're like, ooh, you got a lot of plaque in there. What are we gonna do? What's that procedure called? Yes, we can go in and get rid of that plaque. Maybe there's a blood clot in there. They can go, there's a cool video on YouTube. They can go and get a blood clot. All right, I'm gonna see if I missed anything now that this is working. Google is like anyone can put information in there. So remember your electrolytes, that will become familiar. We talked about this, intracranial regulation, what I needed you to know, I want you to know. Decreased perfusion. So if someone's having decreased perfusion to the brain, they should be restless, anxiety, nervous. If you think of low blood flow to the brain, these are the symptoms that you could be having. Confusion, fatigue, ataxia, and that's low perfusion to where? Ataxia. What is ataxia? Walking, ataxia, I'm not stumbling over. So I have coordination, so where's my the cerebellum? All right, fluids, know your electrolytes, medical emergencies, we still do the ABCs, those don't change. Infections, these are not new to you. So same thing, if there's an infection going on in the brain, it's still gonna have vasodilation, permeability, redness, swelling. That stuff is still going on within the brain. We talk about the nervous system. This is just a nice to know. Here's our myelin sheath. So see how nice and shiny these are? The picture doesn't do it justice. But these are nice and plump and juicy, and they're the ones that send signals to the other neurons to make muscle movement. Serotonin, we don't need to know about that. Acetylcholine and dopamine are lobes of the brain. These are all on Blackboard, so you guys can print them off. So here's the skull. We have meninges that I think, Ashley, you brought up the meninges. That covers and protects the brain tissue in the spinal cord. Because when we're talking about like hematomas, subdural hematomas, epidural hematomas, some of them, they're outside the brain tissue, putting pressure on the brain, or are they inside the brain? Here's our two vessels, blood-brain barrier, we talked about this. another way I've seen on, the internet of how to remember, your cranial nerves, get to know your cranial nerves. Assessment, diagnosis, we'll talk about those with each one. All right, let's do some practice questions for just assessing. The nurse intervenes when the nursing student assesses which of the following: speech formation in the frontal lobe, writing out math equations for the parietal lobe, using the tuning fork for the occipital lobe, having a patient repeat a phrase stated for the temporal lobe. C, why? What lobe is that? Temporal lobe. So yeah, so make sure I know it's easy now, but you guys all have seen what our test questions are like. So just read, trust your gut, you know what you know. So yes, you're correct. C is the incorrect answer. Because we're stopping the nursing student, right? We're intervening, the nurse intervenes. So we're looking for the wrong answer. The nurse anticipates which education statement for a patient who has received a diagnosis of Parkinson's. I know we haven't talked about Parkinson's, we kind of did a little bit with a certain something. So low supply of serotonin is related to depression. Remove scattered drugs to decrease the risk of falls. The lack of dopamine produces tremors and immobility, or areas of the spinal cord control movement. Are they all right? Correct? They're all right.
Yeah,
But go back to the question, because the question is directly associated to Parkinson's disease. Because a low supply of serotonin is related to depression. That's true, but we're not talking about depression. Throw that out. Remove scattered drugs and decrease the risk of falls. Is that true? Yeah, but we're looking at the diagnosis. So throw out B, because that could be someone that's coming home with a hip fracture. That could be our little old lady that has dementia that's now going home because her kids don't want to put her in a nursing home. The lack of dopamine produces tremors and immobility, which is the diagnosis for Parkinson's. And then areas of the spinal cord control movement. That's correct too, but it doesn't have anything to do with the question. So if you're going through your test and you're like, yep, that's right, make sure you read all of them, because technically all of them should be right, but there's always one more right than the other, and that's why we want you to go back and read the question to pick the right answer. The question so that should help you kind of focus in on the right answer. Okay, which technique does the nurse use to assess damage of cranial nerve 8? And our cranial nerves are in Roman numerals, it's not number 8. So which patient presents with symptoms of unsteadiness? But we're only talking about unsteadiness, right? You guys are right. I'm just trying to make you think.
Okay, why is all your answers C?
I don't know. That's a good question. I don't know. I must have Googled them, not Googled them, ChatGPT. I think I made these up myself, to be honest with you. But okay, ask the patient to read the exit sign. We know that's the occipital lobe or cranial nerve, the optic nerve. Have the patient identify an orange with their eyes closed. That's true, but that's cranial nerve 1. Using the tuning fork for a hearing test, and you're like, well, I'm not assessing hearing, I'm assessing unsteadiness. Having the patient stick out their tongue, so that's cranial nerve 12, but the tuning fork is cranial nerve, or the unsteadiness is also with cranial nerve 8, because our balance, remember we have those little crystals in our ears, remember all that from last semester? That help with balance. Okay, you guys get that one? And it's C, unfortunately. Here's the Glasgow Coma Scale. I don't think I'm gonna spend too much time on it because we went through it pretty well. There are two positions I do want you guys to remember. It's this decorticated and debriated position. And I always think decorticated, your arms come to the spinal cord, come inward, so it's by your spinal cord. So it's decorticated. Debriated is when your arms are flat out in your, it's just all bad no matter where it is. Sometimes they're flexing.
But extension away from the body towards
Debriated.
separate.
They're both. Both of them just show that there's some kind of brainstem damage. This is bad when you see this.
It shows brainstem.
Yeah. So sometimes, especially in the debriated, have you like you run into it a lot? Not a lot, but
Not a lot, but usually this means, like, when we see this, they're nothing.
yeah. Debriated is when their arms are stretched out, their wrists are kind of out like that, and sometimes they're pulsing. Why? I don't know. Their fever, have you experienced where their fever is like way high? Yeah. Their fever is way high, but yeah, they're not probably gonna live. This means that there's brainstem damage.
And the other one is, you said.
Decorticated, that means their arms are to their cord, their spinal cord, to help you remember.
Is that like a contraction when they're contraction?
No, it just is brainstem damage. They do this, but I'm just telling you guys to remember the two positions. I had somebody, they like to decorate, so he's like, I would always think about it. He goes, I get to decorate, so decortated.
So decorticated up here.
That's what he said. All right, nursing interventions. I was gonna delete this, but that's okay. So we talked about TIA and stroke. So here's a mini stroke, warning stroke, brief interruptions of cerebral blood flow due to a clot, vasospasms, or arterial hypertension. It's temporary, so a few minutes to 24 hours. They could have the same symptoms as a stroke, blindness in one eye, double vision, unsteady gait, ataxia, I think slurred speech, numbness. So those are the same symptoms of a stroke. But like I said, those symptoms resolve, I should say, after a few minutes. Risk factors, what are our risk factors for a stroke?
Smoking.
Hypertension,
Smoking.
high cholesterol, AFib, diabetes, uncontrolled or controlled? Uncontrolled.
More
Uncontrolled diabetes. Did we miss anything? Sedentary lifestyle, diet, aneurysm, hemorrhage, age. So those are age, family history, gender. Those are non-modifiable. Diagnostics. We're doing carotid ultrasound, CT, angiography, and we're looking at that EKG that we talked about. Focus care. Did I miss any of these? Antiplatelets, control diabetes, and we talked about all this. So your cholesterol comes back in play again. Oh, this is where we got. So the carotid endarterectomy is where they go in and they can clean up the carotids, remove any plaque, any clots, so we get good blood flow to the brain. So, okay, how does the nurse interpret a patient with a Glasgow Coma scale of 3? The patient is stable, the patient is totally unresponsive, the patient had a stroke. I didn't pick C for this one. So which one is it? Where? D. Yeah. I thought someone said B. I'm like, do we know that? 68-year-old Mr. B is admitted following a TIA who is spontaneously resolved. Blood pressure is that. Which action is the highest priority to implement? Ooh, oh, no. Should get B. D. We gotta keep this patient alive, right? So we gotta worry about, what are we worried about? If those symptoms have resolved, are we still worried about a stroke? Yeah, so we're still doing neurovascular checks. So we're checking them frequently. So we will still do neurovascular checks. That's our priority because the sooner we check a stroke, that's the best that we can do. Didn't we have someone at clinical? Not your group, this group. At clinical that had a stroke, but the symptoms started the night before and. That was yesterday, but this was a patient that was already admitted.
Oh, yeah, we did.
Yeah, it was. But, so the sooner you find stroke symptoms, identify it, the better. But yeah, the patient that came in yesterday for the stroke alert, their symptoms started last night, because what is the hour, magical hour that we have? From when the symptoms began, sorry. From when the symptoms began before we can have treatment started with TPA.
3 hours.
4.5 hours. So that means if my symptoms started at 8:30 today, or let's go with 8 o'clock, that's easier to go. So by 12:30 this afternoon, I can get TPA if I have an ischemic stroke. At 12:30, oh, I got it. We
Oh, you
figured
got
it out. Sorry. Yeah,
That's okay.
one of the students figured it out.
Okay,
Or 2 of
wonderful.
the students.
Okay.
Thanks. I forgot.
Oh, it only took them 45 minutes.
We're not. I will. But anyway, so I have 4.5 hours to start treatment, and it is like on the dot. It's like if you go a minute over, I don't want to be the one calling the doctor and go, oh, we didn't start the TPA in time. It's not good. Because this is going to save this person. This is a life-saving medication. Because they have an ischemic stroke, they have a blood clot in their brain, and we got to get treatment to that brain before it becomes permanent damage. So so we have 4.5 hours. That's why when the patient that I talked about that only said 5, he was literally dropped off at the ED. He could only say 5. We couldn't find out when those symptoms started. We didn't know anything, so we couldn't start it. He would have been a perfect candidate for TPA, but because we didn't know that. Pardon me?
Can you write stuff out?
No, couldn't do that. I tried that too. Couldn't write anything out, but couldn't talk, couldn't do anything. But because we couldn't figure it out, we couldn't start that TPA. Because did it start last night? When did it start? We don't know. He was texting at noon though.
What's the risk of starting it too late?
So a fibrolytic called TPA, it will go in and dissolve any clot in your body. So what's the risk of that? Bleeding. High risk of bleeding out. So that risk of bleeding out trumps the TPA at that point. But that is the doctor's decision. Now, have I seen TPA given after that? I have, but let the doctor make that decision. Yes.
So what's the difference in the 4.5 hours that we have to start it versus starting it late? Does it really matter?
Yeah.
I guess
Because
I don't really know how to answer that question, because it's like if they're at a high risk for bleeding already, then we stop. Is that after 4.5 hours?
yeah, when we give the TPA, they're at high risk of bleeding out. So they can live with those deficits. I think, I don't know, depends on the patient, I guess. But they're gonna have to live with those deficits, instead of increasing the risk for bleeding.
What changes after 4.5 hours?
Their brain tissue is dead already. really. The brain tissue is pretty much already dead, so why would we increase the risk of you bleeding out and their damage is already done? I had a friend who, well, not a friend of the family, that he's my age, and this goes back probably 5 years ago. He was at home, he was with his wife. His wife literally just left him, she's a nurse, and she's like, okay, I'll meet you on the road, you go pick up so-and-so at school, and then I'll meet you wherever. Well, the son started calling, he's like, where's dad, where's dad? This is only like 15 minutes later, where's dad, where's dad? So she's like calling him, dad's not answering the phone, so she called my brother-in-law, and she's like, will you go over there? Sure enough, he had a stroke. And they started TPA because it was within the 4.5 hour window, but because of the bleeding, his carotid artery ruptured. So then they care flighted him because now he's bleeding, and I'm like, oh God, this is really bad. But he's alive, he does have deficits, but he's alive.
What kind of deficit?
But
What kind of deficit?
he has trouble walking, and memory is not the best. But yeah, very weak. You could see he uses a cane, but he's my age.
What caused his stroke?
Blood clot, he had blood clot.
Did he have a deficit from the stroke?
Good question. I don't know. Probably from the stroke, I would assume. But yeah, I mean, he survived, so we were able to got him treatment right away. But that's why it's so important for us to educate the community about when those stroke symptoms happen, get them into the emergency room, call EMT, call 911, get them in there right away. Because it can be treated, it just, go ahead.
Do you have to do the non-contrast CT before you start the TPA because of the risk of the hemorrhage already?
Yeah. Yeah. Because if you go in and you start TPA and they have a head bleed,
You're making a risk, okay.
graveyard, yeah.
So if they come in and it's been 4 hours, you have a half an hour to get
You have
your
a half an
CT
hour.
and get that
Protocol is, as soon as the patient hits the ED doors, we have an hour to start TPA, but that is anytime. I mean, that could be, they've had symptoms for a half an hour, so we have an hour. That's just protocol and to keep our certification for being able to start TPA at our hospital. But if they come in at 4 hours, yeah, we only have half an hour. It's crazy.
How
But,
quickly can they do that CT?
pardon me?
How quickly can they do that?
Usually what happens is EMT will bring them in, and I'm sorry, I keep pointing at you. But they bring them in, and the doctor and the nurse are during their neuro assessment walking to the hall to the ED. So they don't usually go to a room, they go straight to the CAT scan. The only incident was Monday night, I told you guys about it, but Monday night we had a stroke alert, he came in, it got canceled because the guy started seizing, he started having status epilepticus. So that was delayed, but it turned out it was just because of seizures. But yeah, that's how important it is to identify that cause, check the bleeding, check the CAT scan first before we do any treatment. Yes,
This might sound dumb.
yeah, you were on the unit.
I just am curious. Obviously, like, if it's past the 4 hours, you can't give them TPA, like, their brain cells are dead. If they get TPA or, like, they get treatment before, I know, like, people can recover from deficits. Like,
Oh, yeah.
certain things can get better or completely go away. I mean, you could recover fully.
Right, it just,
If they don't get the TPA and, like, nothing, like, treats that, is there a way for them to recover? Like, does that make sense? 'Cause
yeah,
obviously
the
it's
the brain, it will do what it wants. You'll get a lot of questions like, well, if their symptoms are gonna recover, when will that happen? And it's like, the brain will do what, you don't know if it will if it recovers, if it doesn't, and usually it takes up to a year. So a lot of people will ask you, well, okay, they had a stroke, when will their symptoms recover? It's like, I don't know if they will. We don't know.
Correct me if I'm wrong, but I just wanna know because I've heard people say this, but I don't know if it's true. Like, when you like recover from the deficits, like that brain part is like dead. Like, it's it's not going to like
Right.
come back to like your other parts of your brain are making up for it.
Yeah, remember you have collateral circulation in the heart where the heart makes up a new pathway for blood. Kind of remember all that. So brain does the same thing. Or if it's past that 4.5 hour window, there are other treatments for the patient. Do they go in and have a bypass of the brain? They can go in with a cardiac or a catheter and they can put TPA just at that spot in the brain, but where they see the clot, but that's a high risk too. Though all of these are high risk procedures that, is it worth death or living with your symptoms right now? But that's for the patient and the doctor to figure out, not me, because I don't make that much money. That kind of money. All right, did we get past this? I'm way ahead of myself. But these are all good questions. All right. Which one is this? The nerves. I think we're past this content. I need to, I don't know. Oh, face drooping. So teach about stroke. I'm just gonna go through these. So here's our stroke. There's two different types of strokes, ischemic and hemorrhagic. So we've talked a lot about ischemic, and the problem with strokes is our blood cannot store oxygen or glucose, so we need that continuous supply of blood to keep our brain working properly. It also removes waste products. And really the type of stroke, kind of like what I was saying with the Broca area or the cerebellum, wherever the stroke is, they'll mimic those symptoms. So that's why I say it's important to know the lobes of the brain, because you might be going through something, assessing a patient, they can do, like, maybe their judgment is really good, but they can't hear, but then we're like, oh, okay, so it's probably the temporal lobe. So you can kind of guess where the stroke is. So when it comes to ischemic, hemorrhagic, we got that. Larger. Do I need to know about that? We talked about cardiogenic. It could be caused by AFib. There are two differences between like a ischemic stroke from do the symptoms gradually appear? When the symptoms are gradually appear, it's usually from plaque. If it happens automatically, like you're fine one day and then all of a sudden you have symptoms, it's probably a blood clot.
And we didn't know the difference between thrombotic or embolic.
I would know which one gradually appears and which one doesn't. So I guess, yeah.
So embolic would be the.
Embolic would be a sudden onset of symptoms.
So that's why this one usually occurs during activity, and the other one occurs during sleep.
Yeah, so with the arthritic or plaque, you're looking at gradual symptoms. What's happening in the back?
Oh, something keeps ringing.
Yeah, but
My phone's here somewhere.
I hear it.
There is kind of like what we were talking about. There's a prenumerate region. So as you can see here, this is the dead tissue. Here is the clot right here, this little wormy thing. So this dead area is dead, but then the area around it could be affected also. And that's called the prenumerate region. COVID, abnormal clotting issues. That's why people are at risk for clots or strokes with COVID, because of that clotting issue. Here's the acronym that you need to know, and we want everyone in the community to know. B fast, B for balance, E for eyes. Can they see? Do they see double vision? Can they read my ID band? Can they read the clock? F for facial droop. Is one side of their face droopy or the other side? Arms arms weak, legs weak. Speech, is their speech slurred? Are they confused? And then time lost, which is brain loss. this is a funny story. So my sister picked up my mom at the airport one time, and it was like a Friday night. I ignored the call because I was like, I'm out, I don't wanna pick up the call. She called back, I said, okay, something's wrong. So she picked up my mom from the airport, she's like, I think my mom's having a stroke. I'm like, okay, great. So I'm like, okay, raise your arms, and I'm doing this on the phone, I'm like, did she raise her arms? Yes. I can hear my mom speaking, so I know her speech is clear. Erin's like, she came off the plane, she was walking fine, so I'm like, well, that I wouldn't, but I thought about it. And then, I go, smile, puff out your cheeks, do all that, raise your eyebrows, and then I hear, I can't. And I'm like, what? She goes, I can't raise my eyebrows. And I'm like, do you get Botox? And she's like, yeah. But my sister said her eyebrows were up to her forehead. And then I was home recently, I'm like, Mom, it looks like Batman instead of Batman. Make sure because, what's it called? Oh my God. That mimic stroke symptom. Bell's palsy, thank you. So Bell's palsy, you might have somebody come in with stroke-like symptoms, but it turns out to be Bell's palsy, but that's next week. Stroke in the cerebellum, inability to walk, problems with coordination, dizziness, headaches, nausea, vomiting. So that's why when we went through the normals at the beginning of class, what's normal? This will help you with knowing where the stroke is. Heart, brainstem. So the thing with ipsilateral and contralateral, ipsilateral means same side. Contralateral, think about contra, other side, opposite side. So our pons is where the cranial nerve crosses. Like we'll have cranial nerves and then they cross sides. So that's why we have contralateral symptoms with a stroke. So if we have a right-sided stroke, meaning their right brain, we're going to have left-sided symptoms because our cranial nerves cross. So that's the meaning of this ipsilateral and contralateral.
And the brainstem stroke is for life-threatening.
Yeah, they're all life-threatening.
Well,
But brainstem is the most, yeah. That's the most. So this is what that means. So if you're having a left-sided stroke, left hemisphere stroke, you're going to have right-sided deficits. And same thing with opposite of the other thing. So left CBA, I always think is your left side is on the smart side. They can do math, they can write, they can speak, they can do a lot of things that are the smart side.
Left is language and logic.
Left is,
You said left is the smart side?
yeah, left is the smart side because they can do math problems.
Left is language and logic, right is reference.
Right side, I'm not good at the right side period because I'm not artsy at all. I was talking to a student yesterday who, if you've been in my office, there's a sketching that she gave me, so I put it in her frame. And some students have asked me if I drew that, and I'm like, oh, hell no, I can only do like stick figures. So I was talking to her about it. But right side is our artsy. So I'm standing here at the room and I'm looking at that monitor and I'm thinking it's like right in front of me. I'm thinking I can reach out and touch it. So my spatial recognition is off. What else? Visual deficit field. So I might be walking, but maybe I only see the left side. So I'm like walking into doors and whatever. I'm tripping over things on the right side because I don't see them. So their spatial recognition is way off. Motor changes. So we have weaknesses and paralysis, gait problems, cranial nerve problems. We've already talked about that. Motor changes. Communication changes. We talked aphasic. We talked about the Broca area and Wernicke area. What was that down there? Appropriate or perceptual changes. So homonymous. Humaniosia, I have to look at it to pronounce it. So this is where, like I said, you only see the half of the visual field. So this is damage in the occipital lobe. So sometimes you'll put like somebody, and you want to always put everything in their field of vision. So if you're giving them a tray, you wanna put all their food utensils in their, say they can see out of the left side. You wanna put it on the left side so they don't have to, they're not confused. You wanna give their medications on the left side of the tray so they can see them and take them. And we'll talk about more treatments after that, because I don't wanna get into this. Or sensory changes, unilateral inattention syndrome. This is also when maybe I can only see the left side. I'm not aware of my right side, so I might only comb my hair on the left side. I only might put makeup on my left side of the face. I might only dress my left side. I'm not aware of my right side. So it's really important to help people do everything on their right side, their deficit side, before they do the other
So
side.
do they know that they don't know about their other side or no?
Probably not. Eye drooping, involuntary movements of the eyes, proprioception, we talked about that, agnosia, loss of ability to recognize an object. So I might be looking at this and going, I don't know what this is, what am I supposed to do with it? So I had a patient one time, this was when we were in the old ED and we were crowded, and I had a patient that came into the ED and we had to put her in the hallway, and all she was doing was crying, and her only complaint was she couldn't figure out how to make her coffee maker. And the EMT said she's not having a stroke. I'm not blaming it on the EMTs. But I was kind of a new nurse, and I'm like, okay, they said she's not having a stroke. She didn't have a stroke. Well, she had a massive stroke. But it was past the time, so that's what makes me feel better about it. Because she woke up in the morning, and let's get back to that, remind me to get back to that. She woke up in the morning and didn't know how to make her coffee maker, or she didn't know how to make her coffee. So that's why, so she had the stroke sometime in the middle of the night. This was in the afternoon.
So this would have been a right?
No, I don't know. No, she just, I don't think so, because she went to bed normal supposedly, but she woke up and had these deficits. So when did the stroke occur? Somewhere. So it could have happened the minute she went to bed. It could have happened the minute she woke up, but we don't know. So that last known normal goes to the night before, because we don't know when that last known normal was. When they're sleeping and they wake up with the deficits, we don't know when that last known normal was. I know, you guys are gonna get a break in a hot second. Yeah. Did I get everything on that? Yeah, unaware of any deficits, that's true, disoriented, time and place, true. All right,